series, and I can't believe it took me 39 years to find what a cool sport. So all right, so we have a case here. This is going to be a human DX case soon. So if you haven't downloaded the app and want to get some daily reps in, download Human DX app, and you can practice your clinical reasoning and get your daily rep in. So this is a case, and it was authored by one of my LECOM students, Michaela Goldgrim, and the title of the case is a 49-year-old presenting with epigastric pain and bloating for 2 days. And that was the first aliquot.
All right. Sarmin and I communicate in code, by the way. If you decipher that, excellent. You will crack our secret communications. This is a very, very interesting space to explore. Actually, one that I reflected on recently. So epigastric pain. The first thing you should realize about epigastric pain is that it is occurring at the juncture between two interfaces, the thorax and the abdomen. It's right there at the border. And anytime you're at the border between any part of the body, say shoulder between the chest and the extremity, hip between the abdomen and the leg, you have to step back and entertain diseases of the adjacent compartment. I think that we learned that concept best in medical school when we're taught about the joint exam, to examine the joint above and the joint below. And I really think that you should examine and assess for the cavity above and the cavity below. So the reason I immediately think of the non-abdominal causes of epigastric pain is because I still haven't fully uploaded this fact yet. I have to actively retrieve it every single time as opposed to it flowing intuitively. So my reflex response is to say, wait, make sure this is not an inferior myocardial wall infarction or a congestive hepatopathy or a PE with infarction or a pneumonia. So I'm there and I'm pushing myself to go there because my intuition tells me that this localizes more to abdominal organs, with the highlight being the pancreas, the gallbladder, the vasculature, and the lumen. And I think that's the space of epigastric pain. There's a lot more detail to it. But with the ER style, thinking practically, the real question in these patients is, what is the length of the workup that we're going to get? So I would love for all of us to both practice our master schema, which is what are all the causes of epigastric pain, but to authentically ask yourself as the case goes along, what is the length of the workup? And I will tell you what is medically acceptable is an H&P and an EKG. In some cases, if the data accumulates, you can stop there. And in some cases, you might need to go to surgery. So there's a very broad array of what you might need to do. So as you practice what is the cause, I'd love for you to also be authentic about how far are you going to go in this patient and why. So those are my reflex responses. I'll pass the mic to Charmaine to see what she would layer on, and then we'll hear from you, Travis.
No, I love that, Robbie, and I totally agree. I think when the differential is so big and it can be something catastrophic to something very benign, then in reality, you would have gone vital signs first, right, to be able to triage that. So again, like not thinking about it as you did RG, pointing to like your no misdiagnosis and keeping that in the forefront, and also like waiting to get some more information before you would go through all the schema and use all of that cognitive function.
So I'm going to give you, since it's a 30-minute, I'm going to compress some aliquots here. So I'll give you a little bit more of the history and past medical history, and then also the exam. So this is a 49-year-old male. He's coming in after he developed some worsening epigastric pain after eating a sandwich. That started about 2 days ago. He tried an over-the-counter PPI without any relief. He denies pain in his chest. He denies vomiting or any changes in bowel movements. He notes the pain is just a bloating feeling that gives him some nausea, and the symptoms seem to get worse every time he eats. His appetite has been decreased because of it. He's never had any of these symptoms before. His past medical history, he's got obstructive sleep apnea, GERD, obesity, alcoholic fatty liver disease, hypertension, for which he takes atenolol. He has a surgical history. He just had a colonoscopy that was normal about 12 years ago, but no other intra-abdominal surgeries. Family history is just squamous cell lung cancer in his mother, and his father died at 24 from a gunshot wound. Social history: he's separated, 5 children. He works as a school bus driver and denies tobacco or illicit drug use. And he drinks several alcoholic beverages per week, probably 6 to 8. Physical exam, which, like Charmaine mentioned, is probably one of the most important ones to kind of differentiate, where are you putting this patient, if they're coming right back, or they can maybe just get something else and go home. Oral temp was 36.2, blood pressure 132/82, heart rate 108, respirations 16, O2 sat 99%. His BMI was 33.7, which puts him at about 253 pounds. He's awake and alert, and he's lying comfortably in bed. On GI exam, there's pain to deep palpation in the epigastrum, as well as a little bit around the periumbilical region. His abdomen is protuberant, and there is a little bit of mild symmetrical distension noted. Otherwise, his pulmonary exam is normal. His cardiovascular exam is normal. There's no JVD. His mouth mucous membranes are moist. There's no conjunctival icterus noted. Musculoskeletal exam is normal. There's no rashes. There's no stigmata of cirrhosis on his chest. And his neurological exam is normal. And that is the end of this aliquot.
Wow, awesome, Travis. How about I focus on the HbA and the past history, and then leave the exam to one and only Robbie MG. So it was one thing that grabbed my attention is like kind of the acute onset that has been 2 days, and that he noticed it after eating a sandwich. So the question is that red herring, or is that the acute pathology? Sorry. Two things that comes to mind is that, like, thinking about, like, is this actually like maybe dysphagia that we are potentially dealing with, or is that like some type of a laceration or something that can happen after like a food if it was like directly related to that acute event. But layering on the background history of this patient, right? He has history of GERD, he has history of alcohol use that predisposes you to like gastritis, can cause esophagitis. So some type of a lesion that can be made worse when you start eating food. The other thing that I think Anne-Marie mentioned this on the chat, and I love, is that, thinking about, like, when people have chest pain, we stress the heart to see what happens, and like eating, it's kind of analogous to stressing the GI tract. So anything that can cause like mucosal surface problems that can be potentially made worse with eating, thinking about vascular etiologies, right? The GI tract has a lot of vessels that, again, like when there's a food, you're gonna need more blood flow there. So if there's any issues with atherosclerotic disease or any vascular issues, can cause pain as well. And then you have your other apparatuses that help with functions like your gallbladder as well. So given the acuity of the event, I'm a little bit more worried about the esophagus, about the stomach, about that event causing something to have happened. But knowing that the background, this is someone who might have had a pathology that is brought out. And then I'll pass the mic to RG.
That was absolutely superb, and I'll say the exam is as expected. The problem with relying heavily on the exam in the patients with chest and abdominal pain is that the exam is designed to pick up diseases that rise to the surface. And only when the surface is very close to the deeper structures, i.e. the face and the extremity, do you have any chance of actually detecting sinister pathology with your exam alone. So the same story gets told over and over again: the pancreas, the gallbladder, the stomach, the appendix, the diverticulum, the heart, pericardium, they just don't rise to the surface frequently in patients. And so here you just have to lean on the fact that this person has sinus tachycardia, telling you that there is likely something more ominous going on inside, and you have to use advanced diagnostics. You have to retrieve the blood from the patient and send it to the lab, and maybe even take a look on the inside with a CT scan. So here, I think what you would do in real life is you would ask yourself, how can I get an answer short of a CT scan? And I think you need an EKG and a troponin, as Hans was pointing out. And you need to lean heavily on your blood tests. Now, the blood test won't tell you the answer in most cases, but they'll tell you whether or not you need to take a look. So what blood tests would be very, very helpful? I think a lipase would be very helpful. Sugar would be helpful for new diagnosis of diabetes, given his past medical history, and DKA. That would be very, very helpful. The other things to think about, not pertinent in this patient, are a pregnancy test to rule out an ectopic, which would be unusual this far up the abdomen, but certainly not something you want to miss. And then finally, the CBC, liver enzymes, and lactate are not going to tell you the answer, but they're going to give you some guidance about either severity or to focus your imaging maybe on the right upper quadrant, which this patient is at risk for given the probability of biliary stone disease. So I'm not surprised there's another aliquot. Give you the mic, Travis.
You got it. So we got some labs and some. We'll do the labs really quick. I'll let you kind of dissect that, and then the imaging will kind of reveal the final diagnosis, unless you can pick it up from here, and I will bow down. So white count was 9.5, hemoglobin 13.2, MCV was 92, platelets 199, the sodium was 136, potassium 4, chloride 105, bicarb 24, BUN 9, glucose was 102, creatinine was 1.13, the lipase was 45 and normal. ALT was 34, normal. AST was 21, normal. Total bili, 0.8. Alk Phos was 60 and normal. A urinalysis was obtained, no white blood cells, no red blood cells, no casts, and a lactic acid was 1.1 and normal. So these are all the labs. The imaging is pending. They're in the CT scanner right now, and they're waiting for you to come back and discuss the lab values.
I love that. In real life, this is I think the part that we were alluding to in the beginning, which is what would prompt you to get a CT scan in this patient? And let me paint a story for why you might not want to and why you should. But then I'll pass the mic to Charmaine to see what she actually thinks is going on. So you could say this is a person with epigastric pain and bloating with an unremarkable laboratory workup. Normal exam, normal workup. Why do you need to image in the first place? And the truth is it goes down to that heart rate of 108. There are many diseases in the abdomen that don't show up on labs. I'd say actually most diseases within the abdominal space don't show up on labs. So the real question in the emergency room is when somebody has positive labs, you need to find an answer. What happens when somebody doesn't have any leading labs? Well, you have to give at least a hypothetical diagnosis, and you only have 4 options. Does this person have heartburn or dyspepsia? And the answer is no, it's too acute. Does this person have constipation? No, it's not something they complained of. Does this person have cannabinoid hyperemesis syndrome? It's not in play. Or does this person have opiate toxicity or opiate withdrawal? Not at play. So the diagnoses that you can tell somebody to not worry about and come back to the ER later are, again, GERD and dyspepsia, constipation, cannabinoid hyperemesis syndrome, or opiate withdrawal. None of them are at play here. So if you just change this history and you said, hey, this person smokes marijuana 4 times a day for the last 20 years, you might stop there. You might stop there. Or if you said this person has had refractory GERD, has had 700 EGGs, and has had 2 prior CT scans, you might stop there. But here, the diagnoses that we tend to make of exclusion to avoid scanning patients, because you can't scan everybody, are not at play. And so I think for that reason, combined with the presence of a major abnormality, which is the tachycardia, and a minor abnormality, which is the pain with palpation, you should proceed despite there being normal labs, in my opinion. Alrighty, Mike to Charmaine for her thoughts and what she thinks might be going on, which is a much harder thing to ask than what I just got.
And no, that was beautiful. And I think the other thing that Chris and me reflecting a lot about is like, we rely a lot on our CT imaging, which is fantastic. And I think it's such a great diagnostic modality, but CT scan is also a product of the function of the time that you do it, right? With especially if symptoms are episodic, you might not capture it. It has, again, like another human is reading it. So definitely, like, I think one good thing with medicine is like always like take it with a grain of salt. But with this patient, Travis has already told us that imaging will reveal the final diagnosis. And I'm just wondering if that sandwich had a toothpick that he accidentally ingested, and that's what you're dealing with. But I think like thinking about that, luminal things are harder to pick up. Sometimes if there's like deep ulcerations, you have a little bit of edema that can be seen on the imaging, but again, like that is usually requires endoscopic evaluation. Thinking about like colitis, appendicitis, you can pick that up on imaging. Again, like the other symptoms doesn't really particularly point to that. So I think like itises is all might be at play. Gallbladder pathology, what you might see like some like gallbladder wall thickening. It can present more acutely, especially if a history of gallstones. So and the fact that the other thing is like because he has LFT abnormalities, doesn't mean you're not dealing with gallbladder, even though they're neighbors and they affect each other. Don't let normal LFT precede you for looking at the gallbladder. I had a very similar patient when I was a resident that I staffed with the one and only group pre-Dhaliwal. And the patient only had on exam tachycardia, and ended up having a really bad cholecystitis with absolutely normal LFTs. So gallbladder continues to humble me. So I don't know, I'm using my favorite phrase. What about you, RG? Any thoughts before we give the mic to Travis?
No, I completely agree with you. I think that I'm struck by the lack of nausea, and I think that tends to be a very helpful clue. Most patients I see with abdominal pain with minimal nausea either have appendicitis or diverticulitis, and in this patient, appendicitis is totally fair game. I think a foreign body ingestion is a very, very good thought that probably wouldn't have crossed my mind. And now that I'm looking closely at it, I would probably go back and see, like, did it start after he ate the sandwich or worsen? And that would be helpful. And I think the no miss when you have periumbilical pain is a vascular event, so a mesenteric arterial or venous mesenteric ischemia. But the truth is that only a radiologist can make this diagnosis. I think it's impossible. I think it's impossible short of that CT scan. But I think if I had to push myself to guess, I would probably guess that mesenteric ischemia is unusual without a prominent risk factor, that diverticulitis is less likely in younger people. And I wonder if this is a sneaky presentation of appendicitis given the periumbilical tenderness to palpation. That would be my guess. All right, Travis, to you, my friend.
Wonderful. So I have some images as well as I can show, but patient went to the answer machine, and like you said, sometimes you have to order imaging at the same time as the labs. So sometimes you don't get the benefit of, hey, I got my labs back 30 minutes hour later, and you order it. A lot of times you got to order it up front. So I wish it was the other way around, but unfortunately sometimes you have to order at the same time. So there was a mesenteric volvulus resulting in focal occlusion of the superior mesenteric vein with extensive occlusive thrombus throughout the SMV, extending to the portal confluence. There was also a subocclusive thrombus in the main portal vein going into the right and left portal vein. There was no evidence of a bowel obstruction, just the mesenteric volvulus, and there was a little reactive ascites in the right lower quadrant. So I got a little image here that I will just show. Let's see here. And it just, this is arrows are you able to see the screen? So the arrows are pointing to the thrombus right in the portal vein here. And this was just another CT scan just showing the mesentery, and just another CT scan. And I did a quick little Google image search on what a congenital peritoneal encapsulation can look like. And, sometimes, bowel can be seen in there. So that was the diagnosis, and just a little bit about this etiology and case resolution. So the patient was taken for, one second, for an XLAP to treat the volvulus. They noted that there was a thin film covering the entire small bowel and circumferentially attached to the retroperitoneum. The sac was removed, sent to pathology. The bowel was run through, and a small portion of the terminal ileum was removed and anastomosed end to end. They were kept MPO, bowel function returned to normal, and they, the patient ended up having the, congenital colemic sac that was removed. They took it all out just in the chance that there was another repeat volvulus. So epidemiology of this, congenital peritoneal encapsulation is very rare. It says there's only about 42 reported cases around the world a year, and maybe 2 in the US a year. Most cases go undiagnosed unless they present with a volvulus due to the extra sac containing small bowel, which limits the bowel's movement. And so of note, this extra peritoneal sac is usually created by the 12th week in utero. So that is the case. And thanks for solving it.
This is such a fantastic case, Travis. And it's always, medicine is always so humbling. And I think intra-abdominal pathologies specifically that, a volvulus presents with 0 lab abnormalities. And again, like taking that sinus tachycardia in a setting of abdominal pain very seriously. And yeah, such a humbling case. I think it's a classic grade ED case. I don't think about volvulus as much. Usually my general surgery colleagues are incredibly helpful, but again, it's things to think about. Obstruction, volvulus are all really important, and I'm just impressed by the pathology and relatively benign presentation. RG, what are your thoughts?
Oh my God, that's it. That's my thought. I just want to clarify one thing for me selfishly. So Travis, is the idea that the volvulus then caused venous outflow tract obstruction and caused the clots, or can you enlighten us on the connection between the volvulus and the thrombosis?
Yeah, I think what happens, it twisted around the vein and the mesenteric vein and causes probably just some stasis, which ended up causing that. And what I need to get clarification on is how you would treat that. I mean, do you anticoagulate for 3 months or something like that? That's one thing. That's really the only follow-up I want to get on this is how you treat just like because you can get portal vein thrombosis from diverticulitis and things like that as well. And I don't know, I can't remember the specific recommendations on treatment in that unless portal vein thrombosis from an infection, what it is. But I'm presuming it's probably 3 to 6 months if their workup is negative for something. So.
Totally. To answer your question, my dear friend Rodrigue just Twitter messaged me a question about treatment, and I was like, I have no idea. I'm a DX doc. I don't know how to treat anything, basically. So I don't know how what the recommendations would be in this context. I think I was gonna play a game. It's called Where Can You Volvulus Game, but I think we have too little time. But I'll tell you that it's been humbling reading about volvulus prompted by a patient recently, about the sheer number of places you can actually get a volvulus. I heard of it initially in sigmoid volvulus, and a patient who had a sigmoid volvulus prompted me to do some reading, and there's about 15 places in the body that you can actually develop a volvulus from. So maybe as a fun exercise, when we have more time next time, we'll do it. But I just want you to know that if you dive into this world, you should, because it's rich with learning that you probably haven't had in medical school, at least not something that is set up in any didactic form, but it's an exciting space to jump into. Thank you for an amazing presentation. And I can't wait for this to hit the human DX platform, so I see it again in the future and get it right that time. Maybe not, maybe I'll forget.
Space repetition.
Space repetition, that's right. And I'll pass the mic to Sammy to take us home.
Yeah, thank you everyone for this discussion, and thank you Travis for this amazing case. I never heard of it, and as usual, an amazing discussion, and also the chat was really on fire. So I will just go over some quick teaching points. Ravi taught us that when we think about epigastric pain, and everywhere in medicine, when we think about something between two interfaces, for example, the thorax and the abdomen, we have to consider pathologies in both spaces. For example, in our case, we could think of inferior STEMI, for example, congestive hepatopathy, pulmonary embolism, pneumonia, but also intra-abdominal pathologies or retroperitoneal, hepatobiliary, colonic, gastric disease, pancreatitis, etc. So there's a broad DDX, and there's also a broad way you can go with your workup. And Ravi made us think about how far we would go, and I think that's quite an interesting question. And quick tests you can always get are ECG, LFTs, lipase, troponin, CBC, and BMP. Then we had this complaint of postprandial abdominal pain, which made us think about esophageal, hepatobiliary, luminal, gastric, or duodenal causes, pancreatic, and intestinal blood vessel disease. I'm basically considering eating as a stress test for the GI system and all organs involved with it. Then we had causes of chest and abdominal pain. They can be hard to detect on physical examination because they are deeper in the structures and don't rise to the surface. So we shouldn't really dismiss them and always use indirect findings. For example, in our case, we had this clue of sinus tachycardia, which made us think about the more sinister etiology. Then we approach the problem of abdominal pain and the unremarkable workup. We can think of heartburn or dyspepsia, constipation, cannabinoid hyperemesis syndrome, opioid toxicity or withdrawal, but also other causes of intra-abdominal pathology. As we said, many don't leave a track on the physical examination, but also not on the labs, as we learned from this case. And Charmin taught us that we should always think about cholecystitis because people can have completely normal labs and a benign abdominal exam and still have fulminant cholecystitis. Then we had this interesting diagnosis of congenital intra-abdominal encapsulation, which is very rare and most cases go undiagnosed, which represents a and predisposes to valvulus formation, mesenteric ischemia, and thrombosis. And the main message, I think, of today is take abdominal pain serious in the context of tachycardia. Always consider the 5 emergencies: obstruction, perforation, any sort of itis, ectopic pregnancies, and vascular events. And yeah, thank you so much again for this case. I think we all learned a lot, and all have a great day.
Just masterful. Thank you for such a wonderful, concise run through the case. And Travis, thank you again for stepping in and a masterclass of a case. We really, really appreciate it. All right, I'll see you later.